In our last lecture, we looked at the global impact of ventilation and perfusion on the lung and how this affects gas exchange in relation to the two most important gases of respiration, oxygen and carbon dioxide. In this talk, we're going to look at regional difference in perfusion and ventilation in health in certain conditions, changes in posture, and the difference between normal ventilation or negative pressure ventilation and positive pressure ventilation. Let's start with the healthy, erect patient. To consider this, we can divide the lung into three zones. The upper zone, the middle zone, and the lower zone. On the right side, we look at ventilation, and on the left, we look at perfusion. So, in a normal healthy person in the erect position, ventilation is maximum in the lower parts of the lung and minimum in the upper parts of the lung. And this is really for two reasons. Firstly, the expansion of the chest wall, which provides a bellows for negative pressure ventilation, is most marked in the lower parts of the lung because there is both expansion of the rib cage due to upward-outward movement of the ribs and movement of the diaphragm downward, flattening of the diaphragm. Whereas in the apices of the lung, the chest wall at this point is much more rigid. So that's one reason. The second reason is the degree of inflation of any particular part of the lung at the end of expiration, so just before we start breathing in. In the lower part of the lungs are much less inflated at the end of expiration, and that means that they are maximally compliant. Therefore, as we breathe in, the lower part of the lung can expand most easily and therefore gets the best ventilation. Whereas the upper part of the lung is much more rigid and there's a lot less movement of gas in the upper part of the lung. The upper part of the lung is not completely collapsed at the end of expiration and therefore is less compliant, so expands less during inspiration. What about perfusion? Well, perfusion in this situation really depends on gravity. So as expected, perfusion is maximal in the lower parts of the lung. The ventricles are at about that level, so there's no need to work against gravity. The vessels are bigger and there's less resistance to blood flow. Whereas in the upper part of the lung, the vessels are a bit smaller and also the blood has to move against gravity to get to the apex of the lung. Now if you look at this picture, what you will notice is that ventilation and perfusion match each other. The maximum ventilation and perfusion occur in the lower parts of the lung, or the bases of the lung. The minimum ventilation and perfusion occurs in the upper part or the apices of the lung. And therefore there's matching of ventilation and perfusion, which is important with regard to getting the most out of gas exchange between the alveoli and the blood vessels. What happens with a change of posture? Let's look at a supine lung. This time things are a little bit different. If we look at ventilation, in fact, there is no great difference in terms of the regional variation. The same factors that have affected ventilation in the erect posture affects it in the supine posture. Therefore, there is maximum ventilation in the lower parts of the lung with less ventilation in the upper parts of the lung, because the lower parts of the lung are more compliant and the lower parts of the chest wall move more and therefore create more of a bellows effect. So ventilation is maximum in the base of the lung and minimum in the apex of the lung, just as it was in the erect posture. A little bit different when it comes to perfusion though. Gravity takes over, therefore the most dependent part of the lung is best perfused, which, as we can see now, is the posterior segments of mostly the lower lobe, whereas the upper part of the lung is less perfused. Now we can see that even just changing posture causes a mismatch between ventilation and perfusion, and that can lead to less efficiency in gas exchange. One more thing to talk about in this short discussion is the effect of positive pressure ventilation. We'll keep looking at the supine lung for this, because the supine lung, the lung is usually supine when a patient is being ventilated. There are two big differences in ventilation of the lung with positive pressure ventilation. The first is in the name. The inspiratory pressure is positive, so we are actually blowing air into the lung, as opposed to in normal breathing, when the inspiratory pressure is negative, we are sucking air into the lung. That has a significant effect on blood flow, because with negative pressure there's an increase in blood flow through the thoracic cavity by blood being pulled from the right side of the heart into the lung vasculature. So negative pressure ventilation on inspiration encourages blood flow through the lung. The other thing is that regional variation we saw with negative pressure ventilation no longer applies. So we're not dependent on the bellows effect of the chest wall anymore, and the positive pressure more evenly distributes air throughout both lung fields, throughout all aspects of the lung fields, and if we lose that apex to base gradient. However, when it comes to perfusion, there is still a gradient, with the dependent part of the lung being best perfused and the upper part of the lung, the most superior part of the lung, so that's the anterior lung in the supine patient, least perfused. In addition, there is less blood flow overall, because positive pressure impedes blood flow through the chest, whereas negative pressure encourages blood flow. It sucks blood into the chest. Positive pressure reduces the flow of blood from the right ventricle into the chest. If we think about those two effects, we can see that both will increase ventilation perfusion mismatch in the supine patient with positive pressure ventilation. And that's one of the reasons why we often see a dip in SpO2 in patients when we just intubate them and start positive pressure ventilation. It takes a little while for everything to equilibrate, but that ventilation perfusion mismatch can cause a bit of hypoxia early on in positive pressure ventilation. Okay, so this short talk looked at ventilation in healthy states, normal negative pressure ventilation in the erect posture and the supine posture, and also positive pressure ventilation in the supine posture. If you have any questions, you can ask them in class. Otherwise, we will discuss this further during the semester, and our next talk will look at variations in ventilation and perfusion in disease.